Well, that's usually when they when the announcement comes out.
We'll see what happens.
Somewhere around 10:30, 11.
Well, I might as well just go. Or sometimes it's beforehand.
The proclamation comes out, but then they just send this global email. So if people don't check their email, what do they know?
Still show up.
Yeah.
We'll probably have an exam.
Yeah, I would still go by.
I definitely
Yeah.
still study.
Okay. Things are getting crazier and crazier. Didn't even get to shave this morning. Good one. Yes. So we'll pick up today. As I'm stressing out about the science fair coming up. Just going to zoom the camera out a little bit. Oh, did the wrong thing. Yeah.
You get too close.
My gut feels like it's twisting and turning and twisting and turning, and therefore today's lecture is perfect. The digestive system 3, midgut, hindgut, and the gut rotation. So this is lecture 23, and we'll go through as much of this as we can in the time we have. We have been focusing all along on the attachment of the yolk stalk to the main body, or as we know, the abdomen, the early abdomen of the embryo, as our demarcation for foregut, midgut, hindgut. Today's focus will be on the midgut. It undergoes tremendous elongation, and the immediately adjacent end of the foregut, the upper part of the duodenum, of course, has its derivatives, the pancreas and liver, of course. And we'll see some of that as we go through the discussion today as well. And all the images we see will include the foregut, at least the stomach and that upper part of the duodenum, because we basically know that with the lateral folding, we get a linear gut tube. Foregut, midgut, hindgut. And we know that in the adult human, even the neonate, the fetus, that it's really twisted and contorted, and it's not, obviously not compromised of any blood flow and stuff like that, but it's not just a linear track from mouth to anus. It is very much tortuous in its pathway throughout our abdominal cavity. So if it starts off as a linear structure, and ends up, twisted and contorted, then a lot has to happen. We had mentioned that the midgut ends up herniated into the umbilical cord, the proximal umbilical cord, because initially there isn't enough space in the abdomen for it. We'll see it returning to the abdominal cavity in the lecture today. So the derivatives of the midgut are supplied by the superior mesenteric artery, as we had stated, and it's suspended by the dorsal mesentery. And this term, dorsal mesentery, is the one that persists, or just mesentery proper, into the adult stage, certainly at neonate as well, and earlier in the fetal stage. So it's the small intestine, the large intestine, to the mid-transverse colon, and it's actually the junction of the proximal 2/3 with the distal 1/3 of the transverse colon. And that's important because that's the termination of the innervation by the parasympathetic nervous system through the vagus nerve, ends at midgut, and then the pelvic splanchnic nerves of the sacral parasympathetic nervous system pick up the innervation at that junction with the hindgut. So the derivatives of the midgut are the lower part of the duodenum, the jejunum, the ileum, the cecum, vermiform appendix, ascending colon, and the proximal 2/3 of the transverse colon. Obviously, when you see these within our lecture, it's not really the question, because these are all correct answers, so they are modified if I use that structure on the exam. As we had stated, the midgut has to herniate because there just isn't room in the abdominal cavity in weeks 6 through 10. So there's an elongation that forms the ventral loop. So our straight line gets pinched basically in the center as it's elongating, and it forms a little U-shaped loop, as it's referred to. And this pushes into the proximal umbilical cord through the opening between the intraembryonic and the extraembryonic coelom that we had described before. So the liver and the kidneys really are occupying a lot of the space, and there just isn't room for this this initial loop, midgut loop, to reside there. We will follow it through a 90-degree clockwise rotation around the axis, which is basically the superior mesenteric artery. So the cranial end is going to end up on the right-hand side, and the caudal end is going to end up on the left-hand side, as we will see. I'm going to read this figure legend so we get oriented to the next couple illustrations. It is of the midgut with the other associated structures. So the first panel, panel A, will be about the 6th week, and we'll see the proximal part of the umbilical cord containing that early midgut loop. Excuse me. The transverse sections will be shown through that loop with the relationship of the cranial and caudal limbs to the superior mesenteric artery, as we'd mentioned. And then we'll look at panel B, the later stage, showing the beginning of the midgut rotation. And then we'll see that first 90-degree counterclockwise rotation. I think I said clockwise in the previous slide because the CW was there. It should have been a CCW, right, for counterclockwise. So please make note of that. And the two limbs, cranial goes to the right, caudal goes to the left. And then in C, we'll be looking at about 10 weeks, and we'll see the intestines returning to the abdomen and some further rotation, so an additional 90 degrees. And then in D, about 11 weeks after the return into the abdomen, with an illustration showing the final 90 degrees. So there is a total of 270-degree rotation. It's not complete 360. So rostral and caudal, cranial and caudal, first go 90 degrees, then another 90 degrees, and then another 90 degrees, all counterclockwise. So these illustrations I thought were really very nice to demonstrate that. I like this series. I've always enjoyed teaching the gut rotation since I began teaching in the summer of, or the fall of 1982, so it's been a while. And it confuses people a bit, but it's extremely important to appreciate this so that all of the little nooks and crannies and body compartments, smaller, really minor body compartments within the abdominal pelvic cavity are understood. How is one continuous with another, and what are the risks if you have an incumbent patient on their back and a little bit of bacteria gets in there by whatever mechanism, PID, appendix, whatever it may be, or even ascites fluid. Then where might it be? Turn the patient to put the sheets on in one direction, roll them to their right-hand side. You get all the stuff going over here, and then when you roll them back to the left-hand side, sneaks back into the omental bursa behind the stomach. So all of these types of things can happen, and obviously an intraperitoneal infection is not a very good thing to have. But this study that we're undergoing now helps to visualize that. Let's first orient to this. We see the spinal cord is not shown, but the dorsal aorta is. Dorsal mesentery with continuity over the stomach, so forming the visceral peritoneum on the surface of the stomach, on the organ. Remember, this surface, if we were able to look at it, would be covered with a simple squamous epithelium, the mesothelial lining, a serosal membrane, and secretes serosal fluid into the peritoneal cavity here. So there's a thin film of fluid in there. And this meets again on the ventral surface of the stomach to continue to the ventral body wall as the ventral mesentery. We see that the liver developed within the ventral mesentery, and the pancreas will, at least for the most part, and ultimately be within the dorsal mesentery of the first part of the duodenum. Now these may, along the way, they may keep or may lose their mesentery, and we probably won't get to those slides in this lecture, but that's important to understand as well. So we see the cranial loop proximal to the site where the superior mesenteric artery joins, right at the yolk stalk. We see that that is minimized now, of course. And then the caudal loop extends from there down into the pelvic cavity, the early pelvic cavity. So the cross-section through here illustrated would show us the central axis of rotation, the superior mesenteric artery, cranial limb in yellow, caudal limb in, I guess that's an orange color. So we'll follow that as things happen. Now we have to give attention to the changes in the stomach as well as we proceed. Remember that the dorsal surface of the stomach is expanding, elongating, forming the dorsal, the greater curvature, and the ventral surface, excuse me, my mouse is getting a little sticky there. The ventral surface does not grow quite so rapidly and ends up becoming the lesser curvature. This greater curvature will end up facing the right-hand side, so it's going to get twisted over here after, it'll reposition along with the rotation. So you can see with this counterclockwise rotation that it's going to put a twist toward, on the anterior surface of this structure, put a twist toward the right-hand side. So the posterior or dorsal surface is going to be twisted. It's going to get that torsion to displace it toward the left. So the greater curvature of the stomach is on our left, and the lesser curvature is facing the right. And that's as a result of this counterclockwise rotation, and everything just trying to take up all the space it can. And that reminds us that at this time there isn't space for it all, so there is the displacement into the proximal umbilical cord. So the first rotation then takes place, as we see in this slide. No change in the liver and the ventral mesogastrium. The dorsal mesogastrium is changing only in the contents of what's developing within it between the two layers of the mesothelium. And I should point out as well, we see the reflection of the dorsal mesentery onto the body wall, so it is continuous with the parietal peritoneum. The same as we've seen all along, there is a continuity of those layers where they persist. And the liver ends up within the ventral mesentery, and this ends up becoming the falciform ligament, that term that I couldn't remember a few days ago. So that first rotation occurs. We see that the portion of the cranial loop proximal to the attachment of the yolk stalk begins to crumple up a little bit. And this will be mostly small intestine, obviously, as we recognize it. So that's the first 90-degree turn. And it then will undergo the second 90-degree turn, where here we are seeing that the cranial loop is now taking position posterior to or dorsal to the caudal loop. So they're twisting around each other, and the proximal loop is going to end up plastered somehow behind the cranial loop. And we see that obviously some parts of the duodenum are going to lose their dorsal mesentery. They've already lost their ventral mesentery. Obviously here it ends right here at that falciform ligament, as I had stated. There we go. So it's getting pushed behind the mesentery proper of the small intestine. So it's going to be plastered there, and then it reemerges on the other side. And we see the proximal or cranial loop continuing to bunch up as it's elongating and running out of space. the initial part, I'll say proximal, with reference at least to the yolk stalk, but also to the mouth too, of the caudal loop begins to enlarge, and this is the first sign of the development of the cecum. So we know that right near that yolk stalk attachment to this gut loop, mid-gut loop, is where we're going to have the junction between the small intestine and the large intestine. Somewhere in here will be that junction, right? Especially, obviously, when we see the cecum there. So the ileocecal junction is going to develop right in this area, obviously. And then the caudal loop is still elongating, but not to the same degree as the cranial loop. So it's still staying, relatively straight. And this is important because it will undergo one final elongation after it's returned into the abdominal cavity in that 10th week or so. We see that the dorsal surface of the stomach is now shifting to the left, ventral surface to the right, and we can now see the greater curvature and lesser curvature coming about. And this dorsal mesogastrium begins to elongate, and it ends up forming the omental bursa, the space behind the stomach. And we'll see it eventually will form a long drape that will come over this portion of the caudal limb that ultimately becomes the transverse colon. So we've now gone through our first 90-degree turn and the second. So we're at 180 degrees. I'll turn the pip off for this part. This is a cross-section through an embryo, just about that same stage. And we go back to our old favorite landmark, the spinal cord was the neural tube. Now it's advanced far enough to refer to it as the spinal cord. We definitely see that the vertebra are developing in this area as well. So this is dorsal. As we extend from dorsal to ventral, we try to identify the vasculature in this area, knowing that the dorsal aorta and the venous system that will ultimately become the inferior vena cava would be in that area. And we can see it basically there with branches going out into this tissue in this area. We see the early kidneys developing. This would be, of course, the spleen developing behind the stomach that's cut in a rather oblique angle here. And then this is the duodenum. We'll look at this at higher magnification. There's something in this area, and of course we should be able to predict that that's the pancreas, and this would be the spleen displaced over here. And then all of this tissue is the liver on the right and the left. So it's beginning to occupy more space in the left than on the right, as we had mentioned before. Then your challenge is to identify this structure and what this is contained within it. So obviously this is the attachment of the umbilical cord, and this would be a portion of the gut loop herniating into the umbilical cord. So this is the surface ectoderm, the skin, right? Epidermis, dermis, and then all the underlying tissue is beginning to differentiate into everything that should be there. And we see the early signs of the abdominal muscles here, the three layers. External oblique, internal oblique, and the transversus abdominis already beginning to develop in this underlying mesenchymal connective tissue and muscle tissue and everything else that the mesenchyme turns into. So this is the primary point of this figure that you can, of this image, that you can see a portion of the midgut loop herniating into the umbilical cord. As we go to higher magnification of that box on the upper left, shown right here, where there's a pretty decent cross-section through the first, the more proximal portion of the duodenum. At higher magnification, we orient to the lumen of this portion of the duodenum or duodenum. So we know there's surface epithelium, the lamina propria, then the submucosa, if I can get to it, and then somewhere out here the muscularis interna and externa would be differentiating, and the serosa would be on the surface. It may be serosa a little bit right here, but certainly on this backside, it's lost that simple squamous epithelium, so it's no longer a serosa, it's an adventitia out here, as I described before. So then we can orient to, we won't do anterior and posterior, but because that's not necessary. But the lumen toward the wall, the outer wall, we see structures obviously not right straight in line with the plane of section, so they bend in and out of the plane of section, but we see a couple planes where this system is sectioned within the plane of section, and it has a lumen, so it obviously is some kind of a duct going on out to what looks like the glandular phase, pseudoglandular phase of the lung, right? Except this actually is a gland. It's obviously the pancreas, as the word there says. And this would be the pancreatic duct that is developing from that dorsal pancreatic bud that we'd seen earlier. So what's meant by the rotation? Well, I'll leave that for you to read. And obviously it's formatted to gear you toward visualizing a question or two being generated from that. Continuing then, there will be the return to the abdomen in week 10. This is called reduction. So the abdomen becomes large enough so that the umbilical hernia undergoes reduction. It's reduced in size. And the rotation and the return causes the duodenum, pancreas, ascending colon to become retroperitoneal. So they get pushed, displaced behind the dorsal mesentery of the midgut loop, as with the lower parts of the duodenum, or is just pushed back against the body wall for the most distal caudal loop. So as we get the twist, the duodenum gets pushed back along with the pancreas and the dorsal mesoduodenum. And then as it comes back, the caudal loop is pushed back, and we get our descending colon pushed into the area there. The ascending colon will develop in a moment, as we'll see, and it also will lose its dorsal mesentery and become retroperitoneal. These are structures that would be secondarily retroperitoneal. The kidneys develop outside the parietal peritoneum originally. They're always outside the peritoneal lining, therefore they are primarily retroperitoneal. These structures that we describe here that develop with or within a mesentery and then lose that mesentery support and become plastered against the posterior body wall are called secondarily retroperitoneal. So we'll talk about effusion fascia, which basically is losing that simple squamous layer. So here comes the two parts, simple squamous epithelium, they come together, two layers of flat cells go away, now the connective tissue is just continuous. So we started on the surface of the organ with visceral peritoneum, and it disappears. So when the visceral layer is there, the mesothelium, it's called a serosa. When form the fusion fascia, it becomes an adventitia where the connective tissue is just continuous with each other. So here we can see this. The duodenum is, with this second 90-degree rotation, has been twisted, pushed to the posterior abdominal wall, loses its mesentery, gains through fusion fascia adventitia on its posterior side. I guess I should do it with reference to me. Gets pushed back. Posterior side has adventitia on it, anterior side has serosa. The descending colon did the same thing, came back, lost its posterior mesentery, dorsal mesentery due to the fusion fascia that occurred. That's now adventitia on its posterior surface. On the anterior surface, it's still going to be covered with the mesothelial lining and has a serosa. So it would be serosa on the anterior surface, then that fusion fascia causes the loss of the dorsal mesentery, the two layers of mesothelium, simple squamous cells disappear, and you have an adventitia. So the duodenum onto the jejunum and ileum, the ileocecal junction after reduction ends up in the upper right-hand corner or quadrant, the uppermost portion, right-handmost portion of the upper right-hand quadrant, right? So just inferior to the liver. And the final rotation is when the ascending colon is produced by the drop of the ileocecal junction down into the lowermost portion of the lower right-hand quadrant, where we know our vermiform appendix and cecum are located in the later fetus and the neonate, and of course through adulthood. So if this is week 10 or past week 10, this is definitely fetus, because the fetal stage starts at week 9. So this final drop down here of the elongation of the proximal portion of the caudal gut loop will produce the ascending colon that goes down here and the transverse colon, and we see that now. The final 90-degree turn is the drop of the ileocecal junction from the upper right-hand quadrant to the lower right-hand quadrant. And this is pretty much the adult appearance here. We notice the dorsal mesogastrium forming what is now referred to as the greater omentum, and the lesser omentum is between the lesser curvature, the remnant of the ventral mesentery, the ventral mesogastrium, spreading to go around the liver. So the lesser omentum, greater omentum is produced by the dramatic elongation of the dorsal mesogastrium. Produces this little pocket behind it, the omental bursa, and then this margin right here will continue to elongate and form an apron-like structure that's ultimately called the greater omentum, that hangs over all these structures in the abdominal cavity at birth and throughout life. So we have the ascending, transverse, and descending colon. So obviously the descending colon up to the distal two-third of the transverse colon has been in our conversation today, but it is not part of the midgut. So we had talked about it being pushed back with the reduction of the midgut, but it is not part of the midgut, it's hindgut. But still it is impacted, as was the portion of the foregut, by these events occurring in the abdominal cavity. Then we have to have the fixation of the intestines. So things have moved out and moved back in, 270-degree rotation. Things got to be fixed in place. They can't just flop around all over. Some will and some won't. But as they get twisted and pushed back, then they're going to get that fusion fascia to be held in place. And basically that's what we're going to see. So we're going to look at a ventral view of the intestines prior to the fixation, then a transverse section at the level shown in that panel A, and we'll see the subsequent fusion, and then the sagittal section of the plane shown in A as well, showing the greater omentum, that forming that apron to come down and around, and the arrows will also show the subsequent fusion, and then D will be the ventral view of the intestines after the fixation, E the transverse section after the disappearance of some of the mesentery, especially of the ascending and descending colons. I said they become secondarily retroperitoneal, serosa on the anterior surface, and due to fusion fascia production, the adventitia on the posterior dorsal surface. And then finally a sagittal section showing the fusion of the greater omentum and the mesentery of the transverse colon to form the transverse mesocolon with fusion of the layers. And again, this fusion of the layers is just two simple squamous epithelial cell layers coming together, and then the two layers of these teeny cells disappear. So it's not a magical event that has occurred. So here we see the ascending colon, transverse colon hiding behind the dorsal mesogastrium, now called the greater omentum. At this point, there's still a space within this whole thing. It is two sheets. Eventually, it's going to come together, except right immediately posterior to the stomach. There still will be a little pocket back there, that omental bursa, with an opening right over here where we see the first part of the duodenum meeting the transverse colon. The oops, I'm sorry, it'd be on the back side of the first part of the duodenum there. So you'd be able to take your finger and push it right behind the duodenum here and go right into this space behind the stomach. So the omental bursa remains, and right now it is persistent into this greater omentum, but eventually that greater omentum is just going to come together and fuse and then overlay the dorsal mesentery of the transverse colon, and then the posterior layer is going to fuse with that. So we end up with the greater omentum being continuous onto the mesentery of the transverse colon, the transverse mesocolon. So this is what we're gearing up to see, but obviously from this, the ascending and the descending colon lose any dorsal mesentery that they may ever have had, creates a fusion fascia, adventitia posteriorly, serosa. This is still the mesothelial layer on the anterior surface, so it is secondarily retroperitoneal. It is fixed in place. But the transverse mesocolon, the transverse colon still has its own mesentery, even though it's contributed to by the greater omentum, so it is a mesenteric structure. So there's retroperitoneal structures and then mesenteric structures, and obviously all the jejunum and ileum are suspended by its original dorsal mesentery, so that's a mesenteric structure. So we look at a couple of cross sections there. We see the ascending colon is pushed down in that final 90-degree turn, and it is being displaced posteriorly. So posterior is up, anterior is down, or dorsal is up and anterior is down. The dorsal mesentery is continuous at this stage, at least, onto, it's kind of, everything gets trapped together a little bit with the jejunum, and all of this dorsal mesentery is going to be pushed, displaced posteriorly, form the fusion fascia. This is the jejunum here, I may have called it the duodenum. And then the descending colon that we see here also is being pushed posteriorly. And we actually can see the attachment of its dorsal mesocolon to the posterior or dorsal body wall. So these cell layers come together, simple squamous epithelium disappears, connect collagen fibers, elastic fibers, whatever there is there, become continuous. That's an adventitia, the outer connective tissue layer of an organ where there's not a mesothelium is called an adventitia. It's just collagenous fibers attaching and fixing it to that area. If we look at a mid-sagittal section, this is a transverse section, not showing all the structures, obviously, just an illustration. If we look at a sagittal section and view from the side, we see the stomach with the dorsal mesogastrium forming the greater omentum. As I said, the two layers are still separated. They're eventually going to fuse together. But even though they fuse right up to here and onto the transverse mesocolon, eventually all this extension of the omental bursa will be lost. So the omental bursa will just be this space posterior or dorsal to the stomach. We see the duodenum has been pushed way back to the posterior body wall. Anterior surface at this moment covered with mesothelium. Posterior surface covered with adventitia. So it's secondarily retroperitoneal. Ultimately, the transverse mesocolon is going to cover that as well. So it will not have a mesothelium, a serosa at all, ultimately. But we see the representation of the rest of the small intestine still suspended within the peritoneal area cavity by its dorsal mesentery. And it becomes called the mesentery proper. But you still can refer to each one of them as the mesoduodenum, the mesojejunum, and the mesoileum, obviously. And the vermiform appendix even has its own little remnant of a dorsal mesentery. It is a mesenteric structure carrying the neurovascular bundle, including lymphatics, of course, lymphatic vessels. It looks like what's the vermiform appendix? It's I've forgotten what the little term is for the mesentery there. The mesoappendix. Good morning. I almost said mesosalpinx, but that's the salpinx is, of course, the fallopian tube, so that would have been wrong. So the mesoappendix is there. And of course, that's important in surgery. If you're going to go in there and start cutting, you want to know where the vessels are if you're going to take out the appendix. So we'll see that the greater omentum is going to fuse. We've lost the mesothelium on the dorsal surface of the ascending and descending colon, fusion fascia adventitia dorsally, serosa anteriorly. We see that there's little gutters that form on either side of the colon, called paracolic gutters. And again, these are important. You got an incumbent patient on their back. That's not prone, is it? What's the term for that? Supine, thank you, yeah. And any kind of fluid is going to be collecting there, so if there's anything in the abdominal cavity that shouldn't be there, where is it? In the left paracolic gutter, outer or inner, medial, lateral, whatever you'd use. And of course, it would be the same on the ascending part. And we see this fusion all the way along the dorsal mesogastrium originally, with the dorsal mesocolon, transverse mesocolon, and then the greater omentum fuses together with just an anterior layer and a posterior layer. So we're at the 10 minutes. I'll leave the abnormalities for you to view on your own. 1, 2, and then extends to the hindgut. Well, I appreciate your time and attention. I hope you have a very happy Easter weekend. And we'll sit and wait to see if the governor's going to give us the rest of the day off. Yeah. Thank you very much.
Thank you. Well, I'm going to show up for that exam then at 12.
Yeah, because there have been students that have had real problems in that the professor shows up, administers the exam, and if you're not there,